Welcome to the Functional Neurologic Disorders Society podcast. I'm your host, Erica Cotton, coming to you from Chicago, Illinois, with a special thanks to Michael Romeo, our production engineer, coming to us from Australia, and our content curator, Ingrid Hertzauer, from the UK. This episode is going to cover the FNDS Annual meeting, which took place in early June in Verona, Italy, including daily conference highlights and interviews with several of the conference speakers. This was a multi-disciplinary conference bringing together leading international experts from a range of backgrounds, including neurology, physiatry, psychiatry, psychology, physical, occupational, and speech therapies. And it was in a breathtaking location. Bear in mind, this was recorded on the fly, with only lapel microphones at the Piazza della Gran Guardia in the heart of Verona, and in any corner we could find. This included the grand internal 4-story staircase between the talks, just outside the busy conference venue at the end of the day with everyone chatting, along with noisy Verona street traffic and some interruptions, and in an upstairs gilded conference room with 2-story windows and massive double doors. So the sound quality will be highly variable, which hopefully adds to the sense of the experience. The first day of the conference covered the span of FND mechanisms to therapies, and here are some of the first day highlights. With a functional seizure focus, Stoyan Popgorov presented on the ability to measure emotional activation, connectivity, and the mechanisms of dissociation, and the need for greater classification of dissociation and behavior as it relates to functional seizures. Dara Albert then presented on the importance of the patient story as it relates to functional seizures diagnosis, the use of the SSPNES, a short scale for PNES, and early caveats in the use of AI in functional seizures versus epileptic seizures discrimination. Next, Caroline Hingray presented on the functional seizure nomenclature, going back to labels of witches and hysteria, and the current terms of functional dissociation, attacks versus seizures, and notably the benefits of updated ICD-11 codes that will allow FND to be billed as both a psychological or neurological diagnosis, fully significantly reducing access barriers to care. Kazia Kozlowska then presented her openly available pediatric functional seizure treatment resources, now also adapted for adults, with an emphasis on pain management, autonomic regulation, activated versus calm states, the role of trauma, and managing prolonged seizures in children. Barbara Dorwetsky presented on the diagnostic standards, limitations, appropriate times to start treatment, variability in driving recommendations within functional seizures, and the ILEA guidance, as well as differences in access and coverage for functional seizures from an international perspective. Next up, we had functional movement disorders, starting with Selma Ibeck discussing the neuroanatomical correlates, including supplementary motor area and the temporal parietal junction, along with trauma recall, supplementary motor area and amygdala connectivity, and amygdala and hippocampal volume, along with the role of epigenetics and oxytocin. Then, Jose Fidel Beazabal Cavallo presented updated diagnostic classifications for FND, including the need for bedside signs and tests with good specificity and sensitivity, along with the challenges of variability in FND diagnosis. Complementarily, Marina A.J. DeConning-Tajissen presented on positive signs in FMD, clinical neurophysiology, and EMG patterns. The challenges mostly of having FMD case reports at this point, ballistic movements, distractibility, entrainment, amplitude patterns, and the debate surrounding incongruent findings. This combined with functional and non-functional presentations exploration. Next, Glenn Nielsen presented his Physio 4 FMD, that's the number 4, which is a 9-session workbook manual that's available to the broader public, and his study comparing this to treatment as usual. He discussed outcome predictors and particularly the role of perceived self-efficacy. Lastly, Anthony Lang discussed predictive coding mechanisms in functional movement disorder, including overlap between FMD and chronic pain, placebo, nocebo, and nocebo effects, and early discussion of the role of AI in FMD mechanistic elucidation. The afternoon session was focused on therapy and treatments, with Teresa Serenova presenting on the importance of multimodal treatments, the modest benefits of medication, and cautions regarding medication side effect profiles. Next, Sanjay Paday presented on the transcultural perspectives, including the ILEA focused on functional seizures, the World Health Organization focused on FFD, the lack of medical providers and healthcare resources in many countries, the lack of technology and medicine being a hands-on practice, gender-based access to medical care and gender bias influencing reporting diagnostic and prevalence rates, the role of tiger parenting, an increased frequency of nuclear families, and the staggering statistic that psychotherapy for FND is estimated to only be offered to 4% of patients in India. Christopher Burton then presented on the treatment models in a primary care setting, the spectrum of FND diagnostic and treatment perspectives within the medical community, belief and ability and responsibility to treat, along with the role of education and legitimization and optimization of current care pathways. Lastly, Michael Dilley discussed his model for difficult to treat FND, including the role of expectations, non-recovery, personality such as rigidity, trauma and neurodiversity factors, diagnostic discrepancy and a lack of readiness, and realistic expectations for longer-term factors such as personality and more ongoing psychosocial difficulties. He wrapped up by emphasizing the need for using a formulation-informed treatment model, the FIT model, FIT. And next, you'll hear my conversation with Michael, which we were able to catch each other just outside the bustling conference center in Verona Street side. Okay, I'm here with Michael. Thank you so much. Your talk was excellent. I really enjoyed it, and I'm super thrilled to be chatting with you. Okay, so given those factors that might be more intractable or more difficult to treat or don't respond to the typical brief treatments or more simplistic interventions, that can be very disappointing for patients and providers to understand that not every intervention works the same for every patient. And I think there's kind of also this differing expectation between medical conditions and other conditions that are artificially put in a different box, where there wouldn't be intractable conditions or difficult to treat aspects to conditions that not in the same way that there might be for epilepsy or movement disorders, and how you have those conversations.
So I think it's about having from the outset a very transparent understanding and agreement with the person that you're treating about their particular set of circumstances, their particular illness, the maintaining factors for their symptoms, and being really clear about what is their priority for treatment, and then working collaboratively really on sharing an understanding of maintaining factors to building the formulation in a collaborative way. And so that really needs those kinds of understandings from the outset, an honest contract between you as the person that's providing treatment and the person that's receiving treatment about how this is going to work, that you're going to be able to talk to each other very clearly if something's not working and feel comfortable to be able to raise concerns about treatment when it's not working.
I remember you emphasized that in your talk, the importance of open, clear communication where you tell me if things aren't working, I'll tell you if things aren't working, and having very transparent expectation. I feel like you said that was such a brilliant way to think about it. I think we don't often approach things in that.
Well, I think there's a hierarchical relationship often in treatment, which shouldn't really, the treatment isn't about me, it's about the person getting better.
Right.
And you need to do that on people's own terms, and they need to be prepared to say when it's not working. Similarly, I think on the clinician side, it's really important when a treatment isn't working to be very honest with the person that's receiving the treatment, say, look, this doesn't seem to be working for you. That might lead into a conversation about changing the approach, particularly in interdisciplinary treatment, or it might even be that particular approach isn't going to work, and that you need to shift into a different perspective and a different approach with either a different psychological or other rehabilitation therapy, or indeed that also works with medication management. And there's something about the beliefs about treatment on both sides of that treatment relationship about how it's going to work, and being honest enough and, to be fair, adult enough to be able to have that difficult conversation.
Right. I think it makes providers uncomfortable to tell patients difficult news of this is not going to be quick or easy for you, and this might not completely resolve for you. I mean, we will hold out hope, and there's always room for that, but the reality, the most likely outcome is that there are going to be aspects that are going to remain challenging, and I think that's scary for providers to.
So I always think that as a healthcare provider, you have a responsibility to build optimism and hope. That's part of the relationship, is laying out what's possible and also focusing on working towards a positive outcome. But also at the same time, being able to have that honest conversation about when things aren't working. That doesn't necessarily mean that that's a failure in treatment. It just means that one particular approach might not be the best approach for that person. And rather than keeping going with something which isn't working, to actually say, let's try another way. And sometimes I think we carry on treatments for a long period of time, knowing that they're not working. And actually, sometimes you need to say, let's stop for a moment. Let's pause. Let's think. Let's have a conversation about how we're going to change this. How are you experiencing this treatment? Is this working for you? And equally, on the healthcare provider side, saying, actually, we can see this isn't working. Why? And coming to an agreement about an alternative approach.
Yeah, it's very refreshing to be able to have that option that most realistically fits certain patient situations. And just as we spoke about before regarding the role of nature versus nurture factors in that, and certain personal conditions, personality conditions that are essentially all brain conditions, and the role of situational factors that are more complicated or more intractable and more challenging, which leads me to my next question to pick your delightful brain about how we capture those nature versus nurture factors that do create a more difficult to treat picture, which are often not considered in more research trials or clinical trials, or even in clinical settings. We do the standard basic mood screening, but these other factors, especially personality or psychosocial nuances and complexities, or even just psychosocial severity, for lack of a better word. So how, one, your interest in having those be captured in research and captured as we're studying these conditions, and especially about which interventions work and don't, and in ways we might be able to go about doing that in any sort of standardized way.
So it's a good question. So I think it's got to start off by being able to take a good psychosocial history, and I don't think we always do that. I think biopsychosocial approaches in formulation are often very biological and psychological, but not so social. And so I think our social workers, our social care providers, we need to engage them in this integrated approach in the same way that we need to have medical and psychological healthcare professionals working together. We don't often, certainly in the UK, see social care professionals working in an integrated way with health professionals, even though we have a Department of Health and Social Care. They're about a million miles apart. So I always talk about this problem with integration, not only being between physical and mental health, but then within mental health, you have a divide sometimes between psychiatry and psychology, which is an inappropriate one. And then social care is somewhere outside of all of that as well. So I think that's the first step, is being able to say we need all of these factors integrated into our approaches to people who are, after all, nothing without their environments and the systems around them. But then thinking about how you might research that is tricky, because it's a difficult thing to standardise approaches to outcomes. I think a lot of the information is often qualitative, and that's going to be the qualitative methods are going to be the ones which are most meaningful to people. And trying to, I think, agree with the people that we're working with in treatment and rehabilitation, what kind of outcomes are meaningful to them. And it might be actually a personalised outcome that you're looking for rather than a standardised one. That doesn't help us with research, but it does help us with treatment.
It does. So it sounds like there might be more utility in patient global impression of change and patient sort of impression of importance in terms of factors, and making sure that we're having flexibility versus maybe a checklist of, were these factors present and to what extent.
Certainly that's the way that we work in our group, is to work with the person on identifying what the things are in terms of their values and then their priorities of those values, and then actually crafting the goals which are based on those values, so that you have something which is meaningful to them and that they can buy into. I think it's all too often that interdisciplinary or multidisciplinary teams identify the goals for the person, go to them and say, oh, what about these goals? And they're sitting there thinking, well, that's not really important to me. Whether I can walk 10 yards in however many minutes
and stand up and go this quick.
It's not the thing that's important to me. The fact that I don't have a house or a roof over my head is more important to me, and that might be so I think trying to think about it in a hierarchy of needs way. So if you think about it in sort of Maslow tradition, that if you haven't got the basic needs met, like housing, when you're going to get your next meal, there's no point trying to do very complicated things about psychological factors that might not be as important to the person.
And more nuanced at that point, just completely sort of, just distal to the core of the crux of the problem.
So it has to keep on coming back to that person's particular set of needs at a time. And then I think you can use this formulation-informed treatment approach where you're looking at the person factors, looking at treatment factors, looking at system factors, and then you're coming back after a trial of treatment to see how it's working through measurement, reappraise it after an agreed period of time that you have that period of treatment, and with the person identifying whether there's been change, which you can do in a much more objective way if you've got a measure that you've agreed, and then re-establishing the next phase of treatment and going through the same cycle. So if you keep doing that each time, whether it's a psychological goal or a social goal or a health goal, it doesn't matter really. You can utilise the same approach depending on that person's priorities in that given period of treatment. And that's very effective, and it means that you get these collaborations and very empowered kind of treatment approaches for that person.
Is this part of your formulation informed treatment?
Yeah,
the FIT model. You want to say a little more about that?
Yeah, absolutely. So it's informed by a number of different kinds of approaches. So some of my work previously has been really in brain injury. So I've worked in complex rehabilitation for people with functional symptoms and brain injury predominantly. In the brain injury kind of tradition, certainly in the UK, I've been using with one of my colleagues, Shay Betteridge, who's a neuropsychologist, this approach which is called empowerment behavioural modification. And essentially, again, it's a systemic approach which is utilising motivational interviewing really to get people
I was going to bring up motivational interviewing. I'm so glad you went in that direction. Delightful.
Yeah. So it's getting people to the point that they're ready for that change, that they're identifying the change that they want to achieve, but it's done on their terms. You're empowering them to do that through motivational interviewing. Then building the formulation in a shared way with the person that you're collaborating with on that. And then making sure that the whole system, which doesn't just include the team that the person's working with, so everybody in the IDT, the interdisciplinary team, has to be able to be on the same page on the formulation, but also the wider systems. That could include patients' families, their employers. If they're involved in litigation in a personal injury claim or a clinical negligence claim, it would include lawyers as well, and making sure that everyone has the same agreement about the formulation so that there isn't the inconsistency which can often undermine a person's expectations of treatment if you've got 5 different people telling you different things about what's happening to you. So it's really critical to this approach is building the formulation. And then I think the thing which is an extension of the empowerment behavioural modification approach, which works across neurological conditions, but we're obviously using in functional logical disorder here, is using that formulation to actually inform the treatment approach. So to start off with, obviously as a neuropsychiatrist, one of the modalities of treatment which I'm used to using is medication, and I don't like using...
I like that you refer to that as one modality, right? As if that's not the only modality. There's all these other modalities. It's brilliant.
Well, I think it's the least... It's very interesting. You read some of the kind of reviews of treatment in functional logical disorder, and they say the majority of treatments here were medications. That's not my experience in day-to-day. As a rehabilitationist, really, I'm using the power of different therapeutic perspectives from the quartet of therapy, speech and language therapy, physiotherapy, occupational therapy and psychology, to be able to deliver a bespoke intervention to somebody which is powered by the formulation as being the thing which pulls that together and makes it such an individualized treatment. It's certainly not the kind of treatment which you just wheel out, like you were saying earlier on, about 14 sessions of psychological therapy.
Here's what it's going to be, and this is what they will get right now, because now's the right time and this is the right intervention. What I love
it's quite different from that. But it also has the ability to adapt and change according to the person's circumstances and readiness. But again, the formulation is critical to it. It doesn't matter which treatment modality you're using the formulation to make decisions about what the most important thing is, collaborating with the patient on agreeing what the priority is, and then using the best treatment evidence that you can for that particular problem. Yeah.
Do you know, this is actually reminding me of, maybe too gentle, but just SMART goals, right? Yes. Specific, measurable, achievable, realistic, and timely. It sounds like you're saying use common sense and set a SMART goal for the patient. Yeah. Truly, what is specific and measurable and achievable and realistic and timely for where they are at right now, where they are currently, and make that the goal, the clinical goal with them, jointly formulated, obviously, as you say, versus here's the goal for everyone. The goal for everyone is to use this intervention and get this outcome for you at this time, right now,
Well, and also you can have outcomes which might be very meaningful to you as a clinician, but might have absolutely no meaning to the person who you're treating. So I think often in rehabilitation, particularly when it's being delivered in a less individualized way, if you understand, so the kind of less about the value-based decisions that you're making, more about, I just want to see you adapt your function or improve your function in some way. Making a cup of coffee might not be very important to somebody, but actually there could be a much more meaningful thing. And then you've got to decide how you're going to measure it. But I think getting that balance right about empowering the patient is really critical to the success of this, because I've seen rehabilitation fail on a number of occasions because the person isn't engaged, and maintaining the engagement and that kind of keeping somebody in a service and optimistic about the opportunity for improvement after all is pretty critical to a successful treatment. And then alongside that, you've also got to be working in a shared way. I think we take it for granted that all of our colleagues share these agreements and treatment plans with their patients. I think the majority of people do, but it's not always the case. And then as well, trying to empower the person to self-manage their symptoms. I think we often think about interventions being delivered by therapists and doctors, but actually what we're really trying to do is to get that person to habituate their own strategies. Yeah, absolutely. To be able to have some autonomous management of their symptoms and carry on with higher and better quality of life using those kinds of approaches themselves long after therapy is over. These are they sound relatively straightforward things to achieve, but I think when you've got symptoms that just aren't getting better, you have to go back to that kind of basic, okay, why is this not working? Let's try and look at what the different factors are. Let's try and really prioritise which ones we're going to work on and make those steady gains so that you can start to see achievement. And that's really important in terms of that learned helplessness that can happen when treatment failures or unsuccessful treatment has been the norm for you as a person with symptoms.
I think learned helplessness for providers.
Yeah, absolutely.
I think a big criticism, not the right word, response that I often get when I tell people I work with, my colleagues that I work with them, they're hard to treat. Do they actually get better? That must be. And it's just sort of this bias around complexity or like a helplessness around, there's nothing we could do anyway. And I think that's just, one, that's not true, obviously, but I do think that there's such empowerment of the providers as well to not also fall into a hopelessness trap of either we've got this or nothing, and then we give up, versus we're going to stick with them and we're going to meet them where they're at, and we're going to just keep working away at this together and create a model that allows progression or just accompanying a person through their suffering, a sort of true patient-centered approach in a way that's, I think, not common in a lot of current medical
not as much as it should be.
Not as much as it should be. Just come in here, you get your treatment, and let's make the...
I think as well, like I was alluding to earlier on, there's also having the agreement about when to stop and feeling comfortable about saying, actually, might not be the right time right now. And I think as healthcare professionals, we often feel that we have the responsibility to achieve remission in every single situation. And that might not be meaningful to people, because actually, if they can self-manage and their symptoms become less important and less at the forefront of their day-to-day lives, then actually they can start living their lives rather than focusing on managing their symptoms. And so that is a very subtle but important difference between achieving remission in healthcare, which is what we would kind of look at outcomes in research, often are remission focused. And I think actually to be able to say to somebody, we're going to try for this period of time, and we're going to agree that if this doesn't work, maybe we should take a step back and pause for a period of time, let you get on with your life and try and start to focus on life rather than just treatment all of the time. And that's really powerful to be able to give permission to people to stop, clinicians and people with symptoms, because, I think too often we go after it too hard, and then that in itself kind of fosters this helplessness that we were just talking about.
I could spend so much more time chatting with you, but I know you are a busy man as well, and already getting waved at and said hello and garnered tours, of course. But I can't thank you enough for your time.
It's a real pleasure, Erica.
It has been, I love this topic. I love that it's at FNDS. I love that it's being discussed more broadly, and can't wait to have hopefully future conversations that are longer as well about such an important aspect. So thank you so much.
It's a real pleasure. Thanks for your time as well. Thank you.
I'd like to introduce my conversation with Dr. Gaston Baslet, who is an associate professor of psychiatry at Brigham and Women's Hospital. He has a notable career in functional seizures and especially mindfulness-based interventions. And any day that I get to talk to Gaston is a great day. So I hope you enjoy my next few conversations.
Oh, Gaston, thank you so much for joining me today. I'm very excited to chat with you about all the talks we've seen. Why don't we start with thinking about your impression of the functional seizure talks that we saw, and your favorite parts or highlights about them?
Yeah, thank you, Erica, for talking with me. I really enjoyed the whole day today. The breadth of talks and the depth of the different discussions has been really impressive. I started my career focusing primarily on functional seizures, and usually that's where my heart is, and that's what I paid the most attention to today.
That's such a nice sentiment.
But so I was so pleased to see how rapidly the field is moving. We heard the talk from Stoyan Popkirov about the advances of better understanding the neurobiology behind different semiological signs and symptoms in functional seizures. That's really refreshing, and also breaks the barriers of dualism that we have had for centuries, really.
Way too long.
And then of course the clinical updates and making diagnoses, and Dara presented on some tools that can help supplement the diagnosis, and not replacing, of course, our clinical skills, but helping people feel more comfortable learning about. Some clinicians who may not be familiar with functional dissociative seizures may start becoming more familiar as they start using some screening tools.
Screening tools make it approachable. I feel like if there's a tool, if there's a checklist, people are like, okay, I might not be an expert, but I've got a checklist, and I've got a place to start. Kind of adds that credibility to the approaching the situation.
Absolutely, and I think that also it demystifies some diagnoses, especially diagnoses like FND, that some clinicians may not be very familiar with. Using these screening tools allows them to learn more about it more informally, and that way they may not be the ones confirming the diagnosis, but at least they are the ones raising the suspicion of. And that, of course, helps patients, which is the most important thing, but also helps clinicians start becoming more familiar with the diagnosis and not so frightened by it.
Right, and not just using their version of what screening should be, but using a screening tool that's developed and informed by expert consensus that says these are the factors to consider. So then, ideally, that provider internalizes those aspects and models, and then that becomes their sort of new view of, these are the things that I look out for, and associate with this diagnosis or this consideration, diagnostic possibility.
That's the hope, and we come a long way in other disorders like depression. In primary care clinics, people use already a lot of screening tools for depression, and it's easier now to talk about those things. And hopefully, FND and functional seizures will go in that direction too.
Oh, that's a beautiful sentiment, actually, very much so. Yeah, if it could just be on the same level as a PCP depression screen, a 2-question screening, that would be great. The one thing that I really loved about the talks, especially across the panel, was just the range of treatment options and the lifespan. So the lifespan of functional seizures and treating from children to adolescents to adults, and then how those can sort of cross-apply or sort of be cross-utilized or synergistic in the learning and the application. And I think was a really lovely piece to see. You had a great team of really excellent providers all coming from their unique perspective.
Yeah, and that's something that has been particularly special about this meeting, how much psychological treatment has been incorporated into the content of this meeting. We had the workshop on Saturday where we covered a lot, but also during the talks on Monday on functional seizures, there was more coverage of different psychotherapeutic modalities, and then we covered more psychotherapeutic modalities in the case discussion later today. And I think that people becoming more at ease at using different psychotherapeutic tools to treat these patients can only help our field and can only help patients in finding providers that may feel comfortable treating them, which has really been a challenge for us to treat patients with FND, expanding the treatment providers in the community.
Right. And being sure, I think that the patients have access to a range of options, right? Versus it's one option and that's it, versus here's a range of different modalities or types that certain people find effective, and finding one that particular person gravitates towards or feels like might be helpful or effective, and having treatment choices is such a luxury that I don't think we've necessarily had, but it's great to see it develop. You just kind of see it blossoming in different directions in ways that's really excellent. You mentioned also using community resources and forming allies and partnerships in the community. I wonder if you might talk a bit about how to make that how to approach that and make that successful, because it's not always something easy, and it's certainly not a skill set that's readily taught, at least it wasn't to me, how to form those relationships. And
yeah, it is a lot of what I do. Actually, I feel that in part I set up the patient on the right pathway, and part of what I do after an initial diagnosis, let's say of functional dissociative seizures, and I need to find a psychotherapist who will treat the patient, I try to collaborate with existing therapists in the community and try to find the best fit for them. But part of that also involves an investment in the clinician, in this case myself, trying to educate people, educate psychotherapists about FND, about how whatever treatment modality they're going to be using with the patient, how it can be modified to target FND and the psychological factors that are bringing FND in that patient. So that's where I spend a lot of my efforts, trying to educate clinicians in the community so that they can feel more comfortable treating patients with FND.
Yeah.
And hopefully with FNDS embracing a lot of teaching about psychotherapy for FND, we are already creating resources that can be used. So it can become more easily accessible for clinicians in the community to learn about FND. It doesn't have to be a one-person effort. And that's eventually the goal, right? That psychotherapists in the community don't need to be taught individually one-on-one by the referring psychiatrist or the referring neurologist what they how they should modify the treatment, but we can refer them to resources that are already, trustworthy and that we all agree on.
Right. Wouldn't it be miraculous if it's someday the availability of providers in the community to treat FND and the training that they've gotten is just the same as it would be for anxiety or depression?
That's a dream come true. I don't know if we will be able to see it in our lifetime, but if we can improve access, I think that is the next milestone, I think, for the people that are invested in the development of psychological treatments in FND.
And I've often found, especially in some of my conversations with community providers, they have great foundational skills. They have basic CBT skills, they have good ACT skills, good DBT skills, and they've got all of these great skills, and they don't know to apply it to the symptoms or the situations. And even though it's just like a slight little tweak of, use these skills here, and they're like, I didn't know I could use these skills here. These skills work here. This will do the job. I'm like, just that slight tweak can make all the difference. But I think oftentimes community providers are probably more equipped than they realize for treating FND, and it's just more empowering them that they're doing the right things and that these skills should apply to symptoms. But I don't know if you've had a similar experience or not, or if I've just been lucky.
Yeah, actually, what I think that I do, sometimes I do a little bit of therapy with the psychotherapist so that they are not anxious to treat patients with FND, so they feel more comfortable managing a seizure in the office or actually formulating a plan. And actually, many times what happens, once I explain things, I share resources, they feel much more confident. And one important thing is that I always make myself available to be part of the team, basically. And I think that FNDS in some ways represents, in this meeting, a a worldwide team of experts, and that hopefully each of us can replicate in our communities, and we can in that way, educate clinicians about FND and expand knowledge and expand expertise. I think that that's one of the main goals of the society, helping patients through helping expanding knowledge and expertise about this disorder.
And just comfort with it, treating it not like it's this absolutely terrifying, unknowable thing to treat versus, no, this is a thing, it happens, we've got plans for it, there's things to do about it, in the same way that we do, you said anxiety and depression, that would be, gosh, maybe in my lifetime, maybe, I know, training programs, it's a whole different story, we can get a whole different podcast about influencing.
I think we can. I think that we are in, already in that direction. It's a lot of work. But, this meeting really is a representation of that effort. And we're seeing it here and, a lot of synergism between different disciplines, between even people doing, for instance, psychological treatment for FND and doing, different modalities of treatment. Understanding what they have in common, what they don't have in common, what they offer differently, and how treatment can be customized. I think this is a place to have a dialogue. What I love about the meeting and FNDS in general is that there's not barriers to talk about, the other discipline, right?
Yeah.
I mean, I'm talking with an occupational therapist, I'm talking with a neurologist, I'm a psychiatrist, I'm talking with a bunch of psychologists. So, there's, we all speak the same language, and we feel comfortable saying, "Hey, you know what? This is not my area. Can you
What do
explain
you guys
this
do
to
for
me?"
this? Yeah. What's your approach? Yeah.
And I think that that's what's really invigorating about this meeting is also we're learning, about things that are different, that can really change the lives of our patients. So we're learning with a purpose, right? And we are all, having the same goal. So, very, very enriching and fulfilling.
It is actually. It's every time I walk, just anyone you bump into, you're like, oh, what do you do? Oh, and how do you do? And it's just always an opportunity to learn from someone else's experience and perspective and background in a way that's open and non-threatening. You can just walk up to someone and chat about, who they are and how they do what they do, because we all, like you said, have the same goal.
And also learning different models of care. Other talks, have been showcasing different treatment models. Carla Franz was talking about the nationwide program at the VA. Dr. Henningsen was talking about the program in Germany. Sometimes those programs may be more difficult to replicate in other settings, but at least we can distill some of the ingredients that make, those successful programs, so beneficial to patients.
Yeah, one thing that I really liked about the way this meeting was structured too was the range from, mechanisms, like the specific mechanisms and biomarkers to the extreme psychosocial cultural level, right? It's sort of going from the most micro that you can get to the most macro that you can get in the scale and scope of FND, from, how do we get biomarkers and what's the physiological neuroscientific mechanisms of these conditions to, and when these conditions happen across countries, across the world, what does that look like and how it's present? It's just, I think it's really nice to see a community that's so open, because kind of you usually get the extremes, right? You get like the neuroscience and then on mechanisms, or you get the, we're in treatment, or we're international in terms of our approach, or the cross-cultural approach. But having it all in one place, I hope as we grow, we don't lose that, because I think that's a real strength. But I don't know if I suppose there's pros and cons to having more specialized conferences versus an extremely broad span. But I don't know if you have the same experience of just the span of topics that we kind of are open to discussing here, like it's able to be on the stage.
Yeah, and I think that's again another perk of this conference is that there's no talk in the program that I have looked at that I say, well, I really cannot relate to this. I can relate to everything, of course. I mean, maybe less of an expert in functional neuroimaging, but I still want to learn what functional neuroimaging is telling us about FND these days, and how that informs our treatment diagnosis. Yeah, I mean, I think that's one of the most one of the strengths of this of coming to this meeting. I want to learn everything. And I'm coming back, home with, so much more, enthusiasm about FND and wanting to contribute more, in patient care and, clinical research and that's the ultimate goal of these meetings.
Yeah.
And of course, with the background of a beautiful city like Verona, right?
Can't beat it.
Who can resist to come to
having a conversation on an infinite marble staircase with 3-story windows behind us? I know it's a great setting for a great meeting.
Yeah, absolutely.
It's been thank you so much for taking the time. It's been so wonderful to chat. Always enjoy chatting. And hopefully we'll see you again on the podcast soon.
Thank you. Thank you for the invitation.
Thanks. Conference days 2 and 3 also had some wonderful content, including further FND treatment nuances and FND-associated conditions. Michael Sharp discussed the role of fatigue in the PACE trial, organic versus psychological, and the fact that behavioral has been erroneously labeled to be indicative of something that is not real, rather than a brain-based phenomena. Then, due to some travel challenges and special circumstances impacting planned speakers, Kurt LaFrance stepped in and shared his neurobehavioral therapy treatment model, originally designed for functional seizures, now adapted for functional movement disorders and functional cognitive disorders. Andrew Sullivan then presented on MS and FND, namely that FND is more often misdiagnosed as MS, whereas in the reverse, MS being misdiagnosed as FND is very rare, only 0.4%. Isabel Paris presented on FND comorbidity and Parkinson's disease, identifying FND as a prodrome to neurodegenerative movement disorders and the role of FND as it relates to deep brain stimulation. John Stone then presented on migraines, noting that migraines and FND are 2 of the most common neurology referrals, yet there are only 9 studies considering migraines in FND and 4 studies of FND in migraines. Further, the role of vestibular migraines in triple PD, the theory of allostatic load and a reset, as well as the amplification of a prediction error becoming maladaptive and habitual, the chronic pain overlap and migraine hormonal overlap that may inform FND-focused understanding. Benedetta DeMartini then presented on the role of autism spectrum disorders and ADHD in FND, including the role of interoceptive processing, alexithymia, inconsistency and challenges of study methods, and the reverse gender rates, particularly the higher male prevalence, and the limitations of self-report screening questionnaires versus the gold standard. To continue with day 2, Alan Carson then presented on long COVID, particularly the problem with lumping all severities together, mood predicting cognitive outcomes and multimorbidity, emotional states influencing immunologic function, brain fog and biomarkers within the clinical exam, and the problematic dualist view of biological or psychosomatic, when in reality it's all biological, as well as vaccination is the best way to prevent long COVID. Mark Hallett then presented on Havana syndrome, including information reported in the Journal of Espionage, didn't even know that was a thing, and from the National Intelligence Council. He described anomalous health incidents, AHIs, and the challenge of high intellectual baseline of those impacted, namely government operatives. Core symptoms of directional auditory experience and comorbidity, including daily persistent headaches. This was also in the context of other AHIs, including the Moscow signal decades earlier. David Marino then presented on TikTok tics, including features of complex behaviors and multiple word phrases, and the role of behavioral reinforcement, depressive symptoms, high levels of daily impairment, and borderline personality disorder traits, as well as the rates of phenoconversion to other FND subtypes. Day 3 was then began with wonderful team presentations from Nadine Lennon and Jeffrey Staub on the pathophysiology and treatment for functional dizziness, with a host of mechanistic insights leading to treatment targets, and wrapped up by Noah Silverberg regarding his FCD behavioral health treatment protocol following post-concussive symptoms, as well as the role of cognitive rehabilitation and outcome measurement challenges in functional cognitive disorder. Importantly, the last day also included a patient panel session, including Kim Hearn from FND Action and discussing provider trainings, Bridget Middleton of FND Hope and creating peace, perspectives, equality, accountability, complexity, and empowerment within FND, and Catherine Gill regarding FND co-design in research, training, and policy. Lastly, Colin Alexander discussed lobbying for FND services as a patient advocate. Well, there was slightly more on the last day regarding poster highlights, interoception with Mahinda Yogahara, and emotions from Richard Kanan, and FND as a feminist issue from Coheen McLaughlin. I want to save time to highlight one very important and new piece of the annual FNDS meeting, which was the Education and Training Day that actually occurred one day before the start of the actual conference. So without further ado, I'm going to direct us to my discussion with several of those speakers.
Thank you so much for joining me today and taking time out of your busy conference schedule. I'm very pleased to have you. So my guests are going to introduce themselves and their roles, and then we're going to get into discussion of the Education Day.
Hi, my name is Dara Albert. I'm a child neurologist and epilepsy doc in Columbus, Ohio, and I run our functional seizure clinic. And I was one of the co-chairs and organizers of the Education and Training Day, which occurred the day before the first day.
Day zero, I hear. There was much
Day
talk
zero,
of day
yes.
zero happening.
The day before, the day zero, at the conference in Verona. And I thought it was a really wonderful day full of lots of really useful, practical information, as well as the individual breakout tracks. And I chaired the pediatric track, which was super engaging and fun, and people had a lot of questions and comments and wanted to discuss their experiences, which just really made it a fantastic experience.
Patient engagement or participant engagement really helps
Yes.
with these sort of things, right? Were you
Absolutely.
at all nervous about that at the start, do you think?
Sure. Yeah. I mean, you just never know how people are going to receive. Some people may, you worry that people may show up to a meeting and just want to sit there and absorb.
Day zero before the meeting even.
Yeah,
right?
Exactly. But I certainly tried to be deliberate about throwing out questions to the audience and making sure that people, had the opportunity to have their voices heard. And in fact, we had almost the opposite problem of too many thoughts, people wanting to share and having to move forward with the
keep it moving.
Yes, exactly.
Good problem to have, though.
It was a good problem to have. Yeah, we did actually run over a few minutes in time because of that, but I still think people got a lot out of it.
That's wonderful. Thank you.
Hi, I'm Julie Maggio. I'm a physical therapist in Boston. I work with the Mass General group with David Perez, and I was one of the organizers as well as the chair of the rehab track. I think my initial reflections are just that it was unbelievable to have that many people interested in education and training. I'm personally really passionate about educating other providers and helping to spread the word so that people can all have access to care no matter where they are in the world. So that to me was the most powerful part, to have that many people interested in learning about that is excellent.
Coming to the conference early and paying more. I mean, the Education
Yes.
Day was separate in terms of cost as well, which is huge, even more of a commitment.
I completely agree. And I think the turnout just speaks to the need and speaks to the fact that this is something this community really wants. And as, at all levels, but certainly at least at a basic level, there needs to be some standardized education that we all have so that we feel competent treating these patients.
Yeah. And what a better place to do it than our organization to set
Absolutely.
these standards and lead the pathway, which hopefully this day was a really good first step towards
Absolutely.
making those standard aspects.
Yep.
Can you imagine this then becoming, our day zero? Have you done day zero training? If you standardize it and, where you get the certificate and complete it, you need to call it day zero.
Day zero training.
Have you been day zero training?
Our internal moniker.
Sounds like, this extreme
Sounds like we went on a stealth mission here to get this.
You have day zero FND training? It's like just your standard checklist of at least you're FND certified in something. We should do that.
Absolutely. I like it. You can be our marketing person.
You will get referenced on the podcast.
Okay, and hi, my name is Claire Nicholson. I'm an occupational therapist and I'm the physical therapies clinical lead for the FND rehab service at the National Hospital for Neurology and Neurosurgery in London. And I was on the organising committee for the physical therapies Education Day alongside Julie here. what I was really struck by was there was a real mix in our audience of not just physical therapists, but other professional groups came and sat in on our track and made a really valuable contribution to the discussions and to the question time, and with real interest as to how they can support their physical therapies colleagues, but also really value what we can provide and the help that we can give people with FND. I thought it was a really engaged group. We had lots of excellent questions. I think, again, alongside Julie, I'm really passionate about providing education to improve care for people with FND. And that's what we're trying to do as part of the FNDS.
Yeah. One thing that you mentioned is that other people came and who were not PTs, right? But I think that just highlights such an important aspect of conferences where it's not just, training for this one group, but more people are already going to be here pulling in multidisciplinary so that then you can reach not only training for your specialty, but how then you interact with other specialties and cross-disciplinary training, which is probably core in a condition like FND where there are so many. I mean, gosh, because how many tracks were there for this education? 4?
There were 4. We had a psychology track, a rehab track, a neurology track, and a pediatric track.
And the PEDS track got the benefit of being truly multidisciplinary. So we had PEDS psychiatry, PEDS psychology, PEDS neurology, PEDS PT, and OT.
Yeah, which is amazing, right? And I think especially for a condition like FND, you need that many, you kind of need such a large spectrum of training because it's not, I think, as simple as a single disease or disorder where there's a single treatment and you need to know that one treatment, and once you know that one treatment, then you're done. It's much more multidisciplinary, which is wonderful that it was arranged so broadly. But then one thing that I thought our listeners might be interested in is training can be so broad. It can be from here's the basics to here's the nuance, right? And what level you targeted? Were you? Yeah, I see a smile in response. Curious.
So I would say, as Dara referenced when we were not currently on the podcast talking about the plan, we didn't have the plan for this to be monumental. We really thought this was like, let's see who's interested. We want to provide some basic level of education. Let's see what we get for a turnout. And our expectations were exceeded with the number of people that came. So certainly as an organizing committee, I think something we need to think about and plan for is exactly that. What is the level that people need? Because the educational needs are very different depending on where you are in your journey.
Right.
And basics and fundamentals is one end of the spectrum, but then navigating the complexities is the other. So we certainly tried to kind of meet in the middle with that in different ways in each track where it wasn't all the way to the basic and all the way to the complex, but it's certainly something we've thought about as an organizing committee is how do we target the range of needs when it comes to education.
Yeah, totally agree with what Julie said. And our hope was that everyone who came would be able to walk away with some practical, addition to their practice, some new way of thinking about it, new way of framing, even for the very experienced clinicians, just to hear others' perspectives and other, people's way of doing things can broaden your own perspective.
So now as you're talking about that, I'm now envisioning a day 0 training level A, B, C, and D, right? Where it's like,
she's making more work for us.
You're going to be a D level 0 dayer where it's like you've done the basic training, then you went to the mechanism training and all the checklists, and then all the specialty intervention, you did the complex population, just like right up through. This is
build your training.
This is build your training and then get your black belt day 0 level D FND provider.
Yeah, absolutely.
And then you get actually wristbands, right? And then whatever your training level is, you can wear the wristband. Yeah, it could be a whole thing.
I was just going to say that when we were developing the physical therapies track, it was really clear that there's some common threads between each of the professions. And that really came across in both the training that we delivered, but also in the questions that were asked by members of the delegates. So it's in what we do in FND, we're coming at patients' goals from different angles, but with really common threads in how we're delivering that. So there's quite a bit of overlap, I think.
So I'm hearing of core training as well, like level, and then have you done the core for each of the levels, like the commonalities, which is absolutely
And I really do think it is a disorder or a condition where not understanding what other specialties are doing is just it's going to be a disservice to you no matter what specialty you're in. Yeah, because you really do need to understand it is such a multidisciplinary community. And if I felt like I had no understanding of what an occupational therapist or a speech language pathologist was doing, I think that would make my job much more challenging. Where if you understand each team member's role and that we're sharing common rehabilitation goals, common diagnostic goals, that we all have slightly different ways perhaps of getting there, but that we share a really unified language.
Yeah, and on the diagnostic side, as a neurologist, it helps to instill confidence in how you communicate to patients and their families. I'm going to send you to a psychologist, and then they look at you and say, well, why?
Yeah.
So to
be able to, it's in my head. Wait,
saying,
what?
Right. So to be able to communicate that, what is the effective treatment, and the treatment, for example, might be cognitive behavior therapy intervention, and that is done by a psychologist, or that the occupational therapist is going to help you with X, Y, and Z. So that way we can confidently help patients move forward and get the appropriate services that they need. And that's not necessarily something that I learned in my neurology training. It was like, oh, it's not neurological. Okay, refer on. And so to be able to add that extra layer of dimension to how we communicate to patients and families definitely is very helpful.
You just touched on one topic I wanted to bring up for our listeners too, which is barriers. And you already identified one, probably without even intending to, which is in my training, I did not get insert barrier, right? So inadequate training for how to navigate being a provider for FND on a team or in a system, right? Because I think people are probably lucky if they have a team, right, where you have all of the pieces in one place. That's ideal, but I think a lot of practices, especially if we're looking to grow and expand, are going to be more disparate or more community. We have this community service that does this part, and then there's this service that does that part, and a little more varied. But I'm wondering if anyone else would like to share other barriers to training or to implementing skills that, or even within limitations within the training you experienced regarding working on a team and providing effective treatment.
I mean, I would even take a step further back and say that there's a deficit in awareness. I mean, I don't remember FND, or probably it was called conversion disorder at that point, ever being mentioned during medical school.
Oh my gosh, that's terrifying.
If it was perhaps discussed in a not helpful way. And I certainly recall some of my, professors dealing with, managing these patients in perhaps a very unhelpful ways. We're talking about them in unhelpful ways. So I think, that's a place where we really need to start, is like helping clinicians recognize that this is a thing, this is a diagnosis. It has a basis, a foundation in pathophysiology, and and also that potentially the way we speak to and about patients with this condition can be very stigmatizing.
I might get too triggering is the wrong word, controversial. But I wonder, when I've had similar experiences, right, where I think we all probably have, where it's either not discussed, or if it is not discussed in a way that is professional or helpful or is wildly different than other conditions that we all got exposed to. I mean, you never see someone make pejorative statements about MS or have a tone when you discuss it. And I was really shocked, at least when I started this work, of this diagnosis evokes some really strong reactions and behaviors in people. And what's up with that, right? And I mean, is it fear of is it that they just don't know and they don't feel empowered, or like lacking educational knowledge? Is it ignorance? Is it own personal projections about discomfort with conditions that are harder to explain? And I was just so shocked, because it's the only condition that I've seen to elicit such, and people have very strong opinions about this condition that are sometimes very unjustified. I'm like, what is this? I don't know if everyone had similar experiences, or this is too taboo to talk about, but I did put in our disclaimer for our podcast, we will discuss some controversial things because I think it's helpful, but feel free to omit if you would not like.
I mean, I definitely think you hit on some fundamental truths there that, as physicians and as neurologists, I can speak from that perspective. We definitely tend to fear what we don't understand, or that we don't feel like we can help. So, there can be a fear of walking into a room. And I've certainly heard people say out loud, or get the impression from their implicitly that before walking into the room to talk to a patient with FND, like, this is going to be a tough conversation. They're not going to get it, or they're going to be angry, or, I don't know how to explain this. So I think what you said hits on a lot of those points.
And those are all then opportunities for education, right? Those are avenues for, are you nervous? Don't be nervous to treat FND. Smiley face instruction list, you're going to be okay. Here's the actual number of the time a patient gets mad at you. Like, it's actually very low. Relative. It's just, I'm always surprised. I'm like, people think that this is, I don't get yelled at every day. I actually have a very pleasant time at work. Like this. It's actually I think the expectation is very different. We should probably present data on that at some point.
I agree. I think a lot of the important points have already been discussed. I do think, and when I think about physical therapy education, I think part of the problem is that there's a little bit of a stigma around the disorder that we have not reversed with any education earlier in the training process. So there's not a reliable amount of education in FND education in our PT schooling. It's not a standard part of our board exam. So, the educators are pushing back because it's not on the boards. They have to teach to board level, structure function type situations. And I do think that that is a barrier. Like, we need to get this into PT education earlier, because not having it there just sets us up for more stigma moving forward. And it's important to me that we start there. And then ultimately, as new clinicians are coming out with awareness of this condition, it will become more common for them to be discussing it amongst their peers, and that will bring us forward.
Yeah, actually, you touched on a really important point too, which is the board certification. If it's not going to be considered part of the essential content, you can't justify treating it, because there's so many things that you have to teach in order to meet the board certification.
This has really been like a major discussion for me I'm not an educator by any means. And every time I talk to someone in education specific to physical therapy, that is one of the immediate barriers they bring up is, we have enough content to cover that we have to have covered to get it on the boards. And how do we bump something else to add something? But our understanding of the pathophysiology has grown exponentially, and there's so much more to say than there was 20, 30 years ago. So to me, it's a real disservice if we're not identifying the fact that there's a need. We just moved to getting it involved in our description of specialty practice for neurologic physical therapy specialists, which is important that it's now on there. And at least in residency programs and things of that kind of more specialized training, it's being addressed. But that's a smaller subset of clinicians. And, and ultimately having awareness of this condition, whether you are neurologically informed physical therapist or an orthopedic physical therapist, is relevant. And so to me, we need to start there in order to kind of grow what the future looks like. But you're correct. It's a big barrier with the boards in that component.
Yeah. Just educational access, right? You can't know about it and get proficient if it's not part of the content.
Yep. Yeah.
That's such a good point.
And I was just going to say, with occupational therapy, for those, a lot of people don't know what OTs do, but we are dually trained in both physical and mental health. So that core training makes us ideally suited to working with people with FND.
Oh, yeah.
We don't specifically have education in undergraduate level on FND, but certainly, there's people within the society and people sitting here right now that are really trying to improve education across the board. But education comes back to the grassroots levels as well. As Dara was saying, often you come across colleagues who might have these misconceptions or negative connotations towards the diagnosis. And I think certainly as specialists or any healthcare professionals is just to challenge those misconceptions quietly, subtly, non-aggressively, but taking every opportunity we can to break that stigma down. I think it's just really, really important. Because even in a specialist centre, I do see that, not within my own team, of course, but in the wider context. So it is important to challenge that.
I think also it goes back to a fundamental truth, another fundamental truth of, we need to remind any trainee, any clinician, regardless of what field they're in, that and this is true, everyone with FND is a human being, and that we need to treat human beings with compassion and curiosity and understanding, regardless of what condition they have, right? And we can't learn, practically, you can't learn about every single condition in training, no matter what field you're in. And even if you spent 10 years in school. By the time you get out, there might still be new things to learn. And it's, we are all adult lifelong learners, right? Mm-hmm. But if we approach any patient with curiosity and with compassion, that may come a long way. That may come a long way.
And you were both talking about that, what I'm thinking about too, and I've discussed this with other colleagues, and I love this about this meeting, where you just get to discuss things and then just pieces come in that you're not usually thinking about. And especially for this meeting being so international, right? Is this like cultural perspective and sort of social, societal perspective. And I wonder also how much of the influence of generation, level of training, what their training was like in terms of what the beliefs were taught at that time, as well as generational and cultural beliefs about mental health, right? That might drive some of that stigma, and then the lack of education, then the general resistance to it. And I'm just wondering, as you were talking, I was hopeful. I was like, oh, maybe this will just like phase out, like as we put in more training, then they're all just going to rise through the ranks of having been trained, and we're not going to have any outdated beliefs because those are going to just be outdated. So it was like, just zoning out, but this might be a little too optimistic.
I think it's a start. This is a start. Absolutely. Yeah, yes. And I do actually think on a whole, and I only have, experience in the United States, that the mental health stigma is fortunately seems to be getting, less stigmatized, which ultimately, as I speak to physiotherapists all the time, it's like we have one brain, and this idea that we are going to separate and we're going to stigmatize and we're going to call one part different than another part, and we can't possibly talk to both parts, is just unbelievably outdated. So hopefully that's getting better.
My favorite joke is, I think when I told my husband, I was giving a talk, and I got a comic. So you always get a dualist, right? You always there's a dualist in every audience. Yep. And my husband, he goes, oh, you should just tell a joke. He's like, would all the dualists please raise your hand and move to the left?
That would have been good.
So feel free to, if anyone needs a good comeback while giving a talk in an audience and there's a dualist present, please use that joke and hope it will not be lost on them. But it was hilarious. That's good.
That is really good.
So there are ways to address barriers that include humor as well as education. And I really appreciate, I think, doing it at so many levels, right? Because there's the individual level where you go and commit to training. And I think part of what is so exciting about so many people showing up to day zero here was that shows the commitment, right? Because once there's commitment and once there's a mass, then it's, oh, well, everyone's doing this. This is now the standard. This is what should be done. And then if that is the standard, oh, well, then why don't we make this the standard? And then it's labeled it the standard. And then once you label something the standard, then it's, oh, well, then we should make this a standardized training. And then it's a standardized training. So it's first, and it needs to be on the boards. And it just kind of goes all the way up, just from the person starting and saying, this is important to me. I'm going to commit and I'm going to demonstrate my commitment, which is so key and important. Absolutely. So last question for you all. Future next steps, dreams, aspirations regarding training. I see smiling faces.
I would say lots of thoughts. I don't know that I can summarize that, to be honest with you.
Too many for
I
this.
think my
we
brain.
need another podcast for education and FND.
I think yes. There you go. A whole other podcast, and I need at least 48 more hours to let my brain, think a little bit about some of what happened after the first day. But I think a lot of what we hit on is relevant here. Like, what is the level of complexity? How do we think about the multidisciplinary team and the different pieces of education that you may need outside of your discipline versus within your discipline? What is the involvement of a rehab professional speaking to a group of physicians and vice versa? So I don't know that I have anything concrete other than to say this is an essential component, in my opinion, of what we need to be doing as people who are passionate about helping people with FND. And there's a lot to digest and think about how we can do better, how we can do this differently as we move forward with this idea of education and training.
Yeah, but I'm hearing a concrete takeaway from that would be, we need to keep doing this exact thing that we did at the next meeting, right? At the minimum, continue to do this.
Yeah, I'm probably a little biased in that, given that I was part of the planning, but I absolutely think this is an essential element that cannot go away.
The numbers present on days, I showed up and I was like, oh my God, I expected nobody to be here on, not nobody, but it's usually significantly
We also
less.
really were not expecting 500 people, I can assure you.
But
it's
that. Like, I showed up, I was like, oh my God, did I get the day wrong? Did the meeting already start? Which is definitely evidence this needs to occur again.
1,000% to everything Julie just said. And then I also envision at some point in the future more outreach. So embedding more of this education and training in non-FNDS spaces, right? Like going to our ER doctor colleague conferences, or, just general physio or rehab conferences, or
day zero for their conferences, level A training of entry level for the non-experts. Yeah. It's like a traveling team. I'm not joking. I do support that. I think that would be great.
I was just going to say, are we getting a van and traveling the country? Is that what I'm hearing now?
I feel like there should be, what are they called? Like not a diplomat. Sorry, we're all very sleep deprived. Yes. We need way more coffee. Not the concierge, not a diplomat. Word final.
Ambassador.
Ambassador, yes.
An ambassador.
We need an FND education ambassador to be appointed to go speak at all the meetings and do a day zero level A training for
all over the world.
All over the world.
That sounds like a lovely job. I mean, the amount of travel you'd get to do is quite fantastic.
That would be really good.
Although I will certainly acknowledge that it takes a lot of work and a lot of people and a lot of effort. And so as one of those people, I'm incredibly grateful to all of the other people. And I don't think you could appoint a single ambassador to do this work.
And their entourage.
And their right. Definitely need an entourage. But yeah, we had a fabulous entourage, and I'm super, amazed at what we put together.
Yeah, it's amazing.
Because we're spread out all across the world trying to put this together. So that was an added level of complexity, but I think hopefully it came together okay.
I think it came together beautifully just based on attendance, and the feedback that I've been hearing from people are just like, oh, this was so good in this training. Meeting different people who say, I met so-and-so during this thing, or Claire just getting her picture taken, because you meet people, right? And then people get excited, and then it's, oh, can I have this person's email? And I need someone, and it doesn't matter that they're in Canada or France or the US. It's just, you're finding the community, which is so cool. And it's such a good space it holds a good space to allow people to form those connections, right? Because you can't form a connection if there's not oftentimes a helpful factor, right? A space and a venue and someone saying, discuss, right?
And a shared interest, a shared passion.
Yeah, exactly. Well, this has been lovely. Thanks so much, all of you. And more importantly, thank you for organizing it. Dara, you mentioned the amount of work that went into this for all of you. So on behalf of the entire FND Society and all of the trainees, and now all of our podcast listeners who will benefit from this, thank you for all the work that you put in and for taking the time to talk today.
Thank you for having us.
Yeah, thanks very much.
Yes, it's been an absolute pleasure.
Wonderful. Thank you.
To wrap up, this year's conference was an impressive array, ranging from FND mechanisms and theory to treatment, and in my opinion, a realistic guide not only to the relatively more straightforward basics of FND, if there is such a thing, but truly owning the complexities and nuances faced in real-life clinical care, along with a wide, yet-to-be-achieved research agenda, with hopefully what is just the beginning of expanding the FNDS mission for clinical education and enhancing the availability of FND-aware clinicians across the world. I truly hope you're able to join the next FNDS meeting in person, and I will look forward to seeing you there.